Good morning, everybody. I hope you are all fine and healthy. Okay, so today's topic we are going to present is post-cesarean delivery. Okay, as you know that the cesarean rate is increasing in world over for various reasons. Maybe the commercial reason. The WHO tells that we should have cesarean rate should be around 15%. Whereas certain cases it is essential, cesarean rate is essential because of the breech delivery, primary breech, the perception that cesarean is safer. Then the social influences, sometimes they put a pressure on the doctor कि आज इसका करना है मुहूर्त अच्छा है ये something like that कि आज baby out होना चाहिए. So and benefit to the staff because cesarean give them more money than the normal delivery. And some institution insist कि ज़्यादा surgery करोगे तो आपको ज़्यादा incentive मिलेंगे. So those type and cesarean on demand. Like I told you, somebody says कि आज कृष्ण जन्माष्टमी है, आज ये baby deliver होना चाहिए इतने बजे. Okay, कभी एस्ट्रोलॉजी कोई पंडित जी मुहूर्त निकाल के देते हैं कि आज इतने बजे डिलीवरी होना अच्छा है. So they all pressurizes on the doctor. But these are not the correct thing, and that's why the cesarean rate is rising world over. Okay. The patient can deliver vaginally also, and to the cesarean or the instrument delivery can be there. Okay, but there is a term called VBAC. Okay, so VBAC is a term which means vaginal birth after cesarean section. So if you will find that cesareans are increasing in the society, so there is every possibility is she will again come back to you, then she will now become a post-cesarean pregnancy. Okay, the post-cesarean pregnancy, there are many risk factors. There is a chances of rupture of uterus of the previous part. Okay, so but the many patients can deliver. Even cesarean has been done. The people have tried that there could be a vaginal birth after cesarean. Okay, so normally we have been doing primary cesarean, say primary breech and some transverse lie and other thing, on which this is about rate is about 16, 18 per live birth, about 100 live birth. So whereas the total cesarean deliveries done for other reason can be around say 23 per 100 live. Okay, but we can always do the post cesarean delivery. Okay, so this is it is a pregnancy with a prior cesarean delivery is quite prevalent in the present day obstetrics. This is due to the liberalization of the primary cesarean section with a non-recurrent indication. And it is a high-risk pregnancy. So any previous cesarean is a high-risk pregnancy. Like when you say that patient has got heart disease or anemia or diabetes. So cesarean, if a patient has undergone previous cesarean, it is considered as a high-risk pregnancy. So what is the effect of pregnancy, effect on pregnancy and labor? Okay. If a patient has undergone cesarean, then she has got more chance of developing, having a abortions, preterm labor, normal pregnancy ailment like she will keep on telling कि मेरे यहाँ दर्द होता है, वहाँ दर्द होता है, मुझे constipation है, ये है, पेट में दर्द होता है, ठीक है, difficulty in walking, breathing, okay, then constant pain because the previous cesarean it may cause some adhesion inside the abdomen. Okay, that adhesion may be causing pain. Then the operative interference and incidental morbidity. Then this patient will require either the instrumental delivery or may have again repeat cesarean may be required, which has got its own morbidity. Then when there is a placenta, previa can occur because in a cesarean, when the fertilized egg come, so normally it it will be implanted in the posterior wall of the uterus or somewhere near fundus. But in a previous cesarean case, sometime if the pregnancy occur on the scar, then there could be a adherent placenta or placenta accreta can occur. As you know that there is in the uterus there is a layer which is known as Nita Bush layer. NITA, Nita Bush, BUSH, Nita Bush layer, which does not allow the growing placenta when it is trying to attach to the uterus. So that layer does not allow this chorionic villi to go beyond the basal layer of the uterine cavity. Okay, but in a cesarean, if cesarean has been done at that place, the Nita Bush layer will be absent because in the previous cesarean it was already cut. Now that area is now healed by scar. Now, if the fertilized egg come on the scar and start growing, then that chorionic villi can go into the scar, can go into the muscle, and they can go into the peritoneum. So there could be a then when the baby comes out at that time, the placenta may get stuck there because it is not lying inside the uterine cavity only. It has its chorionic villi has penetrated deep into the muscle. Okay, so that is called placenta accreta, percreta. Okay, increta. So these are the three varieties of abnormal adherent placenta can be there. And in some patient, there can be a postpartum hemorrhage also can be there. What is the effect on the scar? Okay, if there is a scar and the patient is pregnant, the uterus is growing, then the scar will have some tension. It will keep on stretching because the muscle can stretch by multiplying its number of muscle fiber. There can be hypertrophy or hyperplasia of the muscle, and the uterus keep on increasing. Whereas the lower segment, which has been either healed by scar, so it does not do well as compared to the muscle fibers. So this become under stretch and it can rupture during labor. Okay. The classical or hysterotomy scar rupture during late pregnancy, even if the patient is not in labor, but in late pregnancy, say 34, 36, 38, 7 weeks, the patient has not gone into labor. But many in a classical cesarean where a vertical incision was given on the uterus or a hysterotomy was done to remove, say, 24 weeks abortus from the uterine cavity, such scar, they can rupture even during antenatal period or the late third trimester. Okay, and the incidence of incidence of incidence of scar rupture is about 0.2 to 1.5 in the LSCS case. In the case of lower segment cesarean section, it was done. The incidence of rupture is very less, but in case of the upper segment or cesarean section or hysterotomy where the vertical scar was given, the chances of its rupture are 4 to 9%. How does the healing of the uterine wound occur? Okay, the uterine wound is healed by the muscle and the connective tissue. And if the apposition of the margin is perfect, so if you have joined the margin to margin correctly, then it will heal by muscle and the connective tissue. The factors of the prime importance in the impaired healing of the uterine wound are imperfect apposition of the cut margin. If you have not approximated them properly, then the healing will be a problem. Or if the wound get infected, there is a presence of sepsis, then also the wound will not heal well. Or sometimes there can be hematoma formed at the site of sutures. Then the hematoma will also not make the wound healthy. And poor general condition, if the patient is anemic, diabetic, poor nutrition, okay, chronic cough. So those patients, their healing will not be very good. So they'll have a poor scar on the uterus, so which is liable to be ruptured in the subsequent pregnancy or liver, or excessive stretching of the lower segment leading to the diminished vascularity of the muscle. So these are some of the factors which will affect the healing of the uterine wound. But how do you check the integrity of the scar? Okay, the patient has delivered by cesarean. So how do we know if her scar is good or not? So can she be given a vaginal delivery, or we have to do a cesarean again? Okay. In a classical or hysterectomy scar where the vertical scar was given, the following classical section or hysterectomy scar is always weak. Okay, the scar is more likely to give way during the late pregnancy and labor, and with the increased risk to the mother and the fetus. So these cases should be delivered by elective cesarean. Okay, so we should not allow them to deliver vaginally. So there are the two terms called the scar dehiscence and scar rupture. So when we say scar dehiscence, in which the uh, uterine muscle has already torn, but the peritoneum over the is still intact. Okay, that is called the scar dehiscence. You can see the peritoneum will be, when you open the abdomen for cesarean, you will find that the peritoneum is seen at the scar through which the baby can also be seen. Only peritoneum is intact, but you can see the baby through the transparent peritoneum. That is called the scar dehiscence. Okay, so this term is called scar dehiscence. And when we say rupture, then in which all layers are gone. The muscle is gone, peritoneum is also gone, and many times, if the some of the blood vessels which were supplying this muscle at the angle, both sides there is a uterine artery is supposed to be here. If when the scar rupture, then if the uterine artery get uh, involved in that rupture, then that uterine artery will get torn and it will start bleeding. Whereas if somebody has done a lower segment cesarean section scar, then it usually heals much better compared to the classical scar. The various factors for scar rupture are, so on which factor we have to consider this patient, if the patient has got more than one cesarean, okay, then that is not a good case for a vaginal delivery, then we should go for a third cesarean. Okay, so number of previous cesarean delivery is important. Okay, so they have reported that if the patient had a one cesarean in the past, then the chance of rupture is 0.6%. Whereas if the patient had multiple cesarean, then it is a chance of rupture are 1.8%. So if the patient second cesarean, if you allow to deliver, then there can be 3 times chance of rupture of the uterus. Multifetal gestation. Suppose the next time the patient who had a cesarean, she is now have got a twin pregnancy or triplet or quadruplet pregnancy is there. So they say that it does not appear to increase the risk of uterine rupture, but stretch will be more in a multiple pregnancy. Stretch on the scar will be much more if the patient is this time having a multiple pregnancy. Then factor on the fetal weight. If the weight of the last baby was less, okay, say 2.75 or 3, so then if the baby weight is less, then we can give a trial of vaginal birth after cesarean. But if the baby weight is more, say it is more than 4 kg, or if the fetal weight increase, then there is a chance of rupture will be. If it is less than 4 kg, then the chance is 1%. If it is more than 4 kg, then the chance is 1.6%. And if there is a more than 4.2 kg, then the chance of rupture can be 2.4%. So as the weight of the current baby will keep on increasing, so then the chance of rupture of the uterus will keep on increasing. Okay. Then if the patient had a previous vaginal delivery, if the patient had a previous vaginal delivery, then it is a better chance that the patient will deliver this time also. Or if the patient had a previous VBAC, okay, if the patient had a cesarean and hello, if the patient had a cesarean and following cesarean she had delivered vaginally a normal sized baby, this patient has got a better chance of delivering this time also. So a prior vaginal, previous vaginal birth, particularly previous VBAC vaginal birth after cesarean, is the single best predictor for successful vaginal birth after cesarean. So if the patient has delivered, then she has got the best chance of delivering this time also. Okay. So if this is the situation, then it can be success rate of the VBAC can be 87 to 90%. The rate of rupture increase with the successive labor. Okay, but the prior vaginal delivery also increase the chance of a successful vaginal birth after cesarean attempt. One more factor which is important is how long back her previous cesarean was done. So normally we tell the patient who has delivered by cesarean, we tell her not to become pregnant for 2 years. Okay, that is 24 months. So 24 months, the scar can heal better during that time. So interval between the previous cesarean and the when she is going for delivery. So if it is more than 24 weeks, then the chances of rupture are less. But if the interval is less, if she has conceived before 24 months, then the chance of rupture will increase threefold. Okay, say at 18 months, the incidence can be 1.4%, and then there could be a threefold increase in the risk of symptomatic rupture during the subsequent trial of labor compared with the interval greater than 18 months. Then what was the indication for previous cesarean delivery? Okay, so this is also important. So if the cesarean was done for a non-recurrent cause, it may be present in the last pregnancy, say fetal distress. If for some reason patient was having fetal distress and cesarean was done, so it is a non-recurrent cause. Okay. Or if the patient was having breach in the last pregnancy and now it is vertex, so the previous indication is a non-recurrent cause. So it is not getting repeated in this pregnancy. Then what are recurrent causes? Recurrent causes are like contracted pelvis. Okay. So these are the recurrent causes. Every pregnancy, the pelvis will remain contracted. So those are the things we have to consider. Okay. Then prior dystocia. Dystocia means failure of the cervix to dilate is also a very important factor. Okay. So if there is a previous history of prior dystocia, then it lowers the success rate. Okay, it decreases the success of vaginal birth. So what is the difference between the lower segment scar and the classical hysterotomy or a classical or hysterotomy scar? Apposition in a lower segment cesarean section, the apposition, the thin cut margins facilitate the perfect apposition without leaving any pocket. So when you are stitching them, no pocket is getting formed in between them. So they are closed margin to margin. So, but when we give the vertical incision goes into the upper segment. As we know, the lower segment is thinned out during pregnancy or labor, whereas the upper segment is thick. Its muscle are very thick. Okay, so when we try to approximate them, we cannot oppose them together properly, and sometimes there can be a this thing. They may contain blood or some fibrous tissue. Some gap can be there, so that those will not allow the uh, vertical scar to heal properly. Okay, then the state of uterus during healing. The lower segment of the uterus remains inert while healing, and the healing is going on. As you know that the upper segment keep on contracting and involuting and retracting. Whereas the lower segment, no such activity is occurring. Okay, so there it is very relatively less activity is going on in the lower segment. That is why the rest of few days, the healing of the lower segment will be better. Okay, whereas in the upper part is contracting, retracting, and it is so that the sutures will become loose, and this will lead to the imperfect healing. So that is why the vertical scar is not a very good healing. Healing scar is not formed well there. Then the stretching effect. The stretching effect, the scar is made to stretch during the future pregnancy and the normal labor along the line of the scar. So suppose the patient goes into labor of a lower segment, then the stretch will be felt along the line of scar. Whereas in a vertical incision, the stretch is at right angle to the scar. So all the forces, the muscle on the right and left side of the uterus, they are contracting and they are trying to pull apart the scar. In the one on the right side, we pull the scar on right side, other side will pull on the left side. So that is happening during labor. So that's scar. The placental implantation in future pregnancy. So the chance of weakening the scar by placental attachment is unlikely. So it is unlikely that as you know, the placenta is around 500-600 grams, and you have seen the placenta, how big it is. Suppose in the next pregnancy, it is on the anterior wall it is attached to the anterior wall. Then it will be attached to the scar also. Okay. So the placenta is more likely to implant on the scar, and it weakens the trophoblastic penetration or herniation into the amniotic sac through the gutter. Whereas in lower segment, this thing is generally not happening unless it is a placenta previa. So net effect is that the scar of the lower segment is healthy. Rupture may occur only during labor. Okay, difference between this is this can occur during in a classical cesarean. It can occur during pregnancy also. Like patient has not gone into labor, but still it can rupture. So the incidence can be 4 to 9% in a vertical scar, where it is if a lower segment cesarean section, then it is a very less incidence, 0.2 to 1.5. So following rupture, the maternal death is very less. If the lower segment rupture, then the incidence of maternal death is very less, and perinatal death is 1 in 8. So about 8 babies are delivered, only one may have a die, perinatal period. So, but if it is a vertical scar, then maternal death rate increased to 5%. And perinatal death is 6 to 8%. 6 to 8% of the babies born may die during perinatal period. So, of scar rupture or dehiscence during labor. There is no single pathognomic clinical feature that can indicate the uterine scar dehiscence or rupture. The presence of any of the following features should be taken into when you are monitoring the labor, how do you suspect that this patient may be heading for scar rupture? Okay. First indication will if the patient is on an electronic fetal monitoring, CTG. So that is the cardiotocograph is put on the uterus and on the fetal cardiac activity monitoring. If the patient who is having a normal CTG suddenly start getting an abnormal CTG, then you have to suspect there could be something happening to the scar. Then patient may complain of suprapubic pain. Okay. So because of the scar is going to rupture. So scar, when we say scar rupture, it is not the scar of the skin. Okay. The skin scar will never rupture, but just below the skin scar and slightly above, 2 finger above the pubic symphysis, where generally we give the incision on the lower segment, is the place where if the patient feel pain, so the scar on the uterus we are concerned. So that may rupture. Okay, in between, and this pain will persist in between contraction also. So like if you, how do you check it? You have to keep the patient engaged. Her bladder should be empty, so that full bladder can also cause pain if you are putting a hand on the suprapubic area. Then you ask the patient some question कि आप कहाँ रहते हो, घर में कितने बच्चे हैं, आदमी क्या करता है. तो you उसकी जब attention divert करोगे patient की, at that time putting a hand over the area where you can press the area where the lower segment cesarean section was done. So at that time, if the patient, and keep on watching the face of the patient, if you keep on pressing there, if the patient develop the pain, then her facial expression will change. Okay, so from there you can have this patient may be heading for a rupture uterus. Okay, and it will be, and we examine it in between pain. If it is during contraction, the pain is going on, so you cannot tell us whether this is a scar tenderness or not. So when the patient, there is a period when the patient is not between one contraction and second contraction. If your pain is there, then it will tell you there is a scar tenderness is there. Then the shoulder tip pain or chest pain or sudden onset of shortness of breath. Okay, suppose the scar has ruptured and the amniotic fluid has come out, or blood has bleeding is occurring there. So that amniotic fluid, blood, whichever has come out, that can, the patient is in a lying down position, that fluid will go up to the diaphragm. So diaphragm, it will irritate the diaphragm peritoneum. And from there, there is a phrenic nerve. Phrenic nerve will cause a shoulder tip pain. Okay. Sometimes patient can have chest pain or difficulty in breathing, shortness of breath. Then there is an acute onset of scar tenderness can be elicited. Then many patients may have an abnormal vaginal bleeding or a hematuria. So earlier your patient was passing normal urine, suddenly there is a hematuria or there is a fresh vaginal bleeding. So then you have to also think of there could be a rupture of the scar can be there. Then cessation of uterine contraction which were previously adequate. So previously patient was getting a contraction, relaxation, but suddenly those pains will disappear. Patient who was already in labor. So if the scar rupture, then the pain disappear. Patient don't feel pain because even if the uterus is contracting, because of the rupture, the intrauterine pressure is not getting raised. So when the intrauterine pressure, it is getting leaked from the ruptured scar, from where the pressure is going out. So it is just like a आपका जो बैलून फट जाता है आपका, उसके अंदर आप हवा भरोगे तो नहीं भरेगी. सेम वे अगर यूट्रस नीचे से फट गई है, सो यूट्रस अगर कॉन्ट्रैक्ट भी कर रही है, सो द अंदर इंट्रा यूट्राइन प्रेशर नहीं डेवलप हो रहा. जो भी पेन होती है पेशेंट को, इट इज बिकॉज ऑफ द इंट्रा यूट्राइन प्रेशर व्हिच डेवलप्स, इट यूज्ड टू कॉज द लेबर पेन. So once uterus is ruptured, then all the pressure is leaked out from there and patient will not have pain. So then there can be a maternal tachycardia or hypotension, or sometimes patient can go into shock. Then loss of station in the presenting part. Loss of station means if the presenting part of the fetal head, suppose it was at the level of ischial spine or below the level of ischial spine. If the suddenly the uterus has ruptured, then the scar which was there, it will go, presenting part will go up. So that is called the loss of station. Loss of station means पहले वो ischial spine level से भी नीचे न फील हो रहा था, और नाउ अभी जैसे रप्चर के बाद अब वो ischial spine से भी 1-2 सेंटीमीटर ऊपर चला गया. So that is called loss of station. And also sometimes some patient can sometimes give you sense of giving way. उनको ऐसे feeling होती है कि उनके पेट में कुछ something has given way. जो scar rupture हुआ है, some patient can feel it, and some patient may give you history की मेरे को लगता है मेरे पेट में कुछ हो गया है ऐसे. So management of the pregnancy with a prior cesarean delivery. So as I told you, all the previous cesarean are considered high risk pregnancy. Okay, so they should have a regular antenatal monitoring at a frequent interval, like you do for a high risk pregnancy antenatal checkup. You call them more frequently. So but special we do to them during the antenatal period. We inquire about the pain or tenderness over the scar or vaginal bleeding, so in each visit. So we should document it on the your antenatal card. The patient had a previous scar, there was no scar tenderness, and there was no fresh vaginal bleeding. Okay, then when do we hospitalize them? Okay, in case of the previous history of lower segment, if the patient gives history of lower segment cesarean section, so many patients will tell you, they will not tell you that they had undergone lower segment cesarean section or upper segment cesarean section, unless somebody has documented in the discharge slip. Okay, this patient has got a lower segment or a upper segment cesarean section. Okay, normally, so when you discharge a patient, you must always document that there is a lower segment cesarean was done or upper segment cesarean was done. And also sometimes the lower segment, but there was a problem in delivering the baby's head. Then what they do, they give an inverted T incision. So in the upper part of the lower segment, they give 1 or 2 centimeter more cut to help the delivery of the fetal head. That is called the inverted T incision. So lower segment is just like a transverse incision, and whatever the inverted T is, another 2-3 centimeter of upper segment was also cut to deliver the baby. So all these things should be documented on the patient's discharge slip, and also explain to the patient in the language he can understand कि आपको हमने एक upper segment cesarean दिया है या lower segment cesarean दिया है या inverted T incision भी देना पड़ा, so that अगर patient को याद रहेगा तो वो patient will tell you so that you are better prepared next time. So such patients are admitted at 38 weeks. To assess that, we assess and plan what is the line of treatment. Okay. So what is the plan of delivery? As we have already told you, if there is a previous classical cesarean section or hysterotomy scar, that is a vertical scar, then the best choice is to do repeat elective cesarean section as soon as the pregnancy reaches 38 weeks. So why at 38 weeks? Because we told you that such scar can rupture even during antenatal period. Suppose we allow her to go to 40 weeks. So during those 40 weeks, next 2 weeks, the patient's uterus can rupture. That's why we don't give them any chance to go into labor, and at 38 weeks only we deliver them. But if the patient has got lower segment cesarean, then she should have a mandatory hospital delivery. It should not be done at a primary health center at outpost. Okay, all the previous cesarean section scarred uterus, they should be told to go to a higher center where the facilities for emergency cesarean blood transfusions are available. So they should not deliver at a primary health center or an outpost or a place where cesarean cannot be done in emergency. Okay, so the patient should be sent well in advance to a place center where the facilities are available. So what are the predictor for vaginal birth after cesarean? Okay. So the prior non-recurring indication, like I already told you, if there was a last time breech presentation and this time it is vertex. Okay, last time there was a fetal distress and this time there is no fetal distress. So this is a good indication. So woman having a prior vaginal delivery, if the patient had a prior vaginal delivery, so means even after cesarean she can still deliver uh, safely. Estimated weight of the baby. So the how do you know the weight of the baby is going to be? So there are one is the ultrasound people also tell you what is the estimate. They measure the baby's biparietal diameter, they measure the baby's femur length, and they also measure the third parameter, that is the abdominal circumference. So the your ultrasound machine is a computer. So if you give these three parameters, then there are some tables in that computer. If these parameters are like this, the baby is going to be this much weight. Suppose the baby is 4 kg, 4.2 kg, or whatever the weight they will give you. So that is called the estimated fetal weight. There is another formula called Johnson's formula for estimated fetal weight. So you can check from your obstetrics book. There will be a Johnson's formula. Just read about it. Just by the symphyso-fundal height. So from pubic symphysis to fundal. Okay. If they see the in centimeter, they see how much. Suppose it is 36 centimeter. Symphyso-fundal height is there. Now there can be two positions. One is the head is engaged or head is not engaged. If the head is engaged, then the height of symphyso-fundal will decrease. Okay. Then then in that case we subtract 11 from 36. Okay. If the head is not engaged, the head is floating, free floating. In that case, we subtract 12 from that 36. So whatever the reading comes, so from 36 you minus 11 if the head is engaged and 12 in case the head is not engaged. So whatever the centimeter will come, you multiply this figure with a 155. Okay. So it is a constant number 155. That will tell you the estimated fetal weight of the baby. So actually it can be 375 gram plus or minus, but a rough estimation it will give. So 155 you multiply, that will tell you the estimated weight of the fetus in grams plus minus 375. So by ultrasound picture and by Johnson's formula, you can have an estimated fetal weight can be known. The spontaneous onset of labor is always successful in a week. अगर patient अपने आप ही labor चला जाता है, so those patients they behave better in a vaginal birth after cesarean. And if the patient has already come to you in labor, he on admission her dilatation is more than 4 centimeter, then the success rate of vaginal birth are higher. Obese and elderly women, they have got a lower success rate. The vaginal birth after cesarean, some people have also used the term POLAC, is the TOLAC, so which means trial of labor after cesarean. Some books they have come out with this term like trial of labor with the after cesarean. So the success rate of VPAC is about 70 to 76%. Okay, so it is very beneficial if the 70 to 76% of the previous cesarean patient can deliver vaginally, and with the risk of maternal mortality 0.2 to 1. Okay, perinatal mortality very less. Okay, scar rupture is 0.2 to 1, and mortality is very less in lower segmentation. Perinatal mortality is less. So it is worth giving a trial, but patient should be able to willing to participate. You tell the counsel the patient about all the advantages disadvantages of VBAC. And if the patient is still willing for a vaginal delivery after cesarean, then only you will. If the patient refuses, then you can't help it. You have to do cesarean. The maternal and perinatal mortality rate following VBAC trial of labor are same when compared for an elective cesarean birth. So whether you are delivered by vaginal birth or by cesarean, mortality and perinatal mortality rate are comparable. Suppose there is a suspected maturity, you are not sure what is the period of gestation. Cannot remember her LMP properly. He is giving you wrong date. So in that case, and you get an ultrasound will also not help you much. In that case, you wait for the onset of labor pain or the rupture of membrane, whichever is there. So means if the baby, the pregnancy would not have gone beyond this thing. So then you manage them as a better to avoid a this thing, to deliver a premature baby early by doing cesarean and all. So then it is better to wait till the natural onset of labor. Okay. Or if the membrane has ruptured. So these are the two conditions, then you decide when to deliver them. Vaginal delivery, if previous section was done for some non-recurrent indication and the uterine scar is sound, the vaginal delivery is to be planned. The selection criteria for cases of for VBAC. So normally they say one or two previous cesarean. I'll say we should attempt generally one previous cesarean. Two previous cesarean, you can decide for the repeat cesarean. Then non-recurrent, the indication should not be non-recurrent. The pelvis should be adequate for this fetus. Okay. Then continued labor monitoring should be possible, so that continuous monitoring by the CTG should be possible. And then there should be availability of resources like anesthesia should be available, blood should be, transfusion should be available, OT should be available. In case we are suspecting that this scar is going to rupture, there is an impending rupture of the scar if you suspect. So by the symptoms I told you, if there is a tachycardia, fetal distress, or loss of station, or loss of well-established uterine pain, or there is a fresh vaginal bleeding. If any of these things are present, then we should be able to immediately deliver the baby by cesarean section within 30 minutes. That is why VBAC should not be tried in a primary health center or outpost, or a place where the cesarean is not happening. Okay, it is not even a primary health post. If the then you will transport the patient, then you are losing time. Patient mortality will increase. So that it should be an institution where within 13 minutes you can open the abdomen and deliver them. So it should be an informed consent of the woman is to be taken well in advance after proper counseling. Then management of labor and delivery. If the spontaneous labor occur, it is always desirable. But as you know, some patient will not go into labor, but the induction of labor with prostaglandin increase the risk of uterine scar rupture. This you must keep in mind, so that you have to be very cautious if you are giving a prostaglandin. If you should maintain an intravenous IV line with a ringer lactate, the hemoglobin should be known, blood grouping and cross-matching, one blood should be available. Then the patient should be monitored clinically for scar dehiscence, and also CTG electronically monitored, see how the patient's heart is behaving. So, and then we see the progress of labor. Okay, the analgesia and epidural analgesia is not contraindicated. It is neither delay the course of labor nor delay the diagnosis of scar rupture. So in case you feel the patient require obstetric analgesia or epidural, you can give. Oxytocin for augmentation of labor may be used selectively. Then electronic fetal monitoring is desirable, and the prophylactic forceps or ventouse may be used to cut short the second stage of labor. Suppose the head is fully cervix is fully dilated, head is down. Then you, in a normal pregnancy, it will take 1 hour or 2 hours. In a multi, it will take 2 hours. 1 hour for second stage of labor to delivery of the head. Okay, and in a primary, it may take 2 hours. So here, but in this case, we have to cut short the second stage. As soon as you feel the cervix is fully dilated, head is down, you can apply vacuum and deliver, so that you don't allow the uterus to undergo repeated contraction for another 1 to 2 hours. So this is the scheme of management of pregnancy with the prior cesarean section. So patient should have a regular antenatal visit. She should be hospitalized. In case of the lower segment scar, so you admit at 38 weeks. Okay, in case of classical scar or a hysterotomy scar, you admit at 36 weeks. Okay, so you observe for 2 weeks in the ward, and when patient reaches 38 weeks, you do an planned elective cesarean and deliver the patient. So, but in case of lower segment cesarean, you assess the case and you formulate your how to deliver. There are two options. You can deliver by VBAC or you can plan an elective cesarean. So in case you decide for elective cesarean, go ahead. And when the patient is, you feel his lung maturity is there, you can go elective cesarean. So if you want vaginal delivery, then you follow the guidelines of VBAC. Okay, then if the progress is unsatisfactory, when we are planning VBAC, you have to do under double setup ki labor room you are trying to deliver, also keeping her ready for cesarean. So in some patient, the progress will be unsatisfactory as you are charting the partogram. If you find the partogram is not progressing well, then it is better to do, or there is a evidence of scar tenderness developed. In that case, you can plan a cesarean section. Can be okay, but if the labor is progressing smooth, then you can use the vacuum delivery in the second stage and deliver. And so once patient has delivered, then exploration of the scar after expulsion of the placenta. Once the placenta is out, then you can put your finger into the lower segment and see for any rupture there through the vaginal route. Okay, sometimes you can find a scar. In one patient, I applied vacuum. Suddenly, I found the momentum is coming out into the vagina. Okay, so then that's how we suspected there would have been a rupture. But baby has come out healthy after vacuum. Nothing happened. Patient was not bleeding. Most of the patient, what rupture is the scar rupture. As you know, the scar is a avascular structure. Okay, avascular structure, if it rupture, there will not be any bleeding. In many patients, in which we said we have to open, then in that case, there was no scar tenderness. There was no blood in the abdomen in most of the patient. This will only occur in case uh, in this case, it will only occur in case sometimes there are two options. When the scar rupture, it can rupture only slightly, say 2-3 centimeter it has ruptured. Then it could be a scar dehiscence. The peritoneum is still present, but baby will still be remaining inside. Then sometimes the whole scar can rupture. Okay, then peritoneum has also ruptured. Baby is visible when you open the abdomen, but it may be in the uterus. In some cases, before rupture, the last push of the uterine contraction may push the baby into the abdominal cavity. So sometime you will find the baby has been delivered, but it is lying in the abdominal cavity. So in that case, your part will be, baby's limbs will be felt superficially, and you have to do an emergency cesarean, and you can still save the baby to certain extent. Okay. And many times the blood may not be required. It will be only required when whole baby comes out through the scar into the abdomen, and the previous scar has extended, and it has involved the uterine artery on the right side or left side, and which has also now started bleeding. It will only in those cases it will be required. Otherwise, you will be finding it there. Then many times the scar when it ruptures, and uh, you can just like any other cesarean, you can deliver the baby and suture the scar. But if the scar has been torn very badly, in those cases, sometimes sometimes you have to sometimes you have to cut the uterus also, remove the uterus. That is called peripartum hysterectomy or caesarean hysterectomy. Okay, there are some benefits of the VBAC are there is a decreased maternal mortality, infection, reduced length of hospital stay, decreased need for blood transfusion, decreased risk of abnormal placentation, means placenta will not get attached on that. So complications of unsuccessful VBAC are maternal, it can cause a uterine or womb dehiscence, uterine rupture, increased blood transfusion, increased hysterectomy due to uterine rupture. Sometimes infection can occur and morbidity. And perinatal in the baby can be born with a lower CAR score. Okay, contraindication for VBAC are the classical or inverted T-shaped uterine incision, the 2 or more previous cesarean section, CPD, and if the patient is having any other complication like previous cesarean with any medical problem like preeclampsia, malpresentation, placenta previa, or any other medical problem, in that case, we should not, more than one factor, we should not try a VBAC. Okay. Then the resources are limited in a place where this emergency cesarean cannot be done, or there is a history of prior rupture. Okay. Okay, I'll show you a small so I'm showing you a uh, small video in case you can appreciate. So this was a previous cesarean with a breach, and when we opened, we found that it is already ruptured. The baby parts were visible. You can see without any without you can okay. You could make out something. Okay, thank you very much. Time is over. Thank you, sir. Okay.
Thank you, sir.
Thank you.